I think we can get started. So thank you everyone for being here. This is actually our first seminar, I think, in our Ease of Research series for 2025. We started our Ease of Research initiative around a year and a half ago. We got really good feedback from our investigators, passed it on to all of our different branches of research, including OCR. And Robin, you have seen our survey on, we obviously have some work to do, and we understand part of it has been staffing and all the other changes which have went over Emory system over these last couple of years. But clinical trials being a very big portfolio of our department, we want to make sure that our clinical investigators and clinical investigative teams have their, voice heard. So we thank you for coming today. So everybody, I want to introduce Robin to you. You guys know Robin Jin. She's our Associate Vice President for our Office of Clinical Research. Robin has this really tough job of looking over this team, which is going to looks into research billing, compliance, coverage analysis, budgets, and a lot more, which I cannot even go through. Uh, Prior to joining Emory, Robin actually held the position of Executive Director for Research Informatics and Regulatory Affairs at Vanderbilt University. So she has a lot of experience in many different areas, including IRB, overlooking IRB, HIPAA, and clinical research compliance. As a background, Robin has a BSN in nursing from Southern Illinois University and an MBA from St. Louis, Missouri. Shout out to John Sauer, right, John? Missouri here. Thank you, Robin, for being here, and we look forward to your talk. And we want this to be quite an open, interactive session. So, we will ask our, attendees to please, let us know if you have questions by raising your hand in between. It's a very small panel, so we should be able to look for questions. And Dr. Searles is here, and he's going to manage the Q&A session. Thank you.
Terrific. Well, thank you very much for inviting me. I appreciate it. Can you see my screen?
Not right now.
Do I need to reshare?
Yes.
Yes.
It says sharing is not turned on. A request has been sent.
You should be able to now.
Is it working, Robin?
Can you see it now?
Yes, we can see it now. It's in the, it's not, yeah, you want to change the mode to the presentation mode or slide because
Interesting.
we
We had this all fixed, and let's see.
Now we are reading your email about
Oh, well,
budget.
that's probably not good. So much for having this done in advance. Let's see.
Try sharing again and let's see. Otherwise, we can. Oh, this is good now. This should be. I mean, you can still go into the presentation mode down there if you like. Yes, thank you. Perfect.
Wonderful.
Thank you.
Okay. So we have had a great year in transition. I don't know if people are aware, but we have been going through a lot. In February is when the new Woodruff Industry Clinical Trials group actually was created. During the same period of time, we have been working really closely on the Advera optimization for Encore, which just went live on January 21st. So there has been a lot going on. For those of you that aren't really aware of the Office for Clinical Research, I just wanted to take a moment and help you to understand that we have 5 specific teams in the Office for Clinical Research. We have the Clinical Research Support Services team, and they do a lot of things from user triage, any type of mandatory training that might need to be helped. We provide BLS training. We will actually come and do departmental trainings for those that might need it. And Bridget Benson, who's also on the call, leads that team, and she'll be happy to answer any questions as we all will today. The other team is the pre-award team, and since we now are split off from the industry contracted group, we cover everything else but the industry contracted studies. So we will help do coverage analysis for anything that has a billable item or service. We'll do budget development for any of the non-industry contracted studies. We do not do the federally funded budgets. Those are done within the RAS. We also do something that people don't always know about, and that's letters of intent. So if you're seeking funding from industry sponsors, we'll help you pull a budget together to go out and attract those folks. So if you let us know, we're very willing to help. And then Amanda Hutchison-Rezepka is also on the line, and she leads this group of people as well. So I'm letting you know who they are because they're the first line of escalation and support. You can always contact me at any time, 24/7. The third group that we have is our clinicaltrials.gov compliance team, and I've noticed several of the folks that are actually on this call have utilized our clinicaltrials.gov team. They will help you do for all of the studies where Emory is considered the sponsor. They will make sure that they'll help you do the registration in clinicaltrials.gov, the updates. Some of the updates they came up with have to be done like every 15 and 30 days, but most of them are done every 6 months to a year. They'll also help do the very end point of the results reporting as well. That's Jenny Przanik who leads that team. The next team is the data integrity team, and Vicki Swafford is also on the call. This team actually is the liaison between us and Epic. So they work very closely between the Encore system, pulling data out of our IRB system, and making sure that everything is pushed to the Epic system as appropriate. So sometimes there are issues with the interface of things, making sure that they get from one system to the next. Vicki is your woman. She'll make sure you get taken care of. The last team that we have is the invoicing team, and that's Sherry Coleman and Veronique King, who's on the call. And they will help for all of the industry sponsored or industry supported clinical trials. They'll help with the invoicing for that. So you can tell we have, a group of five teams. They work really super closely together, but the scope of each of the teams might be a little bit different. So I have a lot of slides, but I'm not going to go through the detail on all these slides, just really paying attention to what Dr. Lama was saying. But the first one is the Clinical Research Support Services team. And I'm pretty excited about the things that are ahead. They work really closely to support all of the investigators' initiatives, and they're working from beginning to end, making sure that people understand, the work that needs to be done, not just in Encore and Epic, but also at the time of closeout. I know that Bridget has been working really closely with Dr. Lama, and they have some big plans for this coming year. They started PI consultations this last year, really trying to help, especially PIs that are new to research, new to Emory, or people that just might need a little bit of help. And they're happy to meet with you, help you through the process, help you understand what all of the steps are in the process. I know that Bridget's been working with a team of people, and she can talk about it later if you're interested, but tell you more about, after the time of the ENOA, to actually meet with the study team and say, this is, how you read your coverage analysis. This is how you read your budget. This is what you need to do in the Encore system. These are the things you need to do in the Epic system. So she has a really strong team of people that are very dedicated and really just excel in customer service. So you can see some of the trainings that we do. One of the things is that because most of our coordinators and research nurses are required to have CPR, in the past we had an issue where CPR was not provided by Emory and people had to go outside the institution and pay for it themselves. We started providing that as a service. So anyone that is related to research, the coordinators, the research nurses, we're happy to send them through our CPR training. We talked briefly about the consultations, the departmental trainings, and now just so everybody knows, the Encore training, the whole Encore management and oversight process is being handled through Emory Digital and Research Informatics. So they're also taking on all of the training. This is just at a glance, and you can look at this later. We're not going to go through it, but this gives you an idea of the types of training that is required and when it is required. So, not all of the training is required in all circumstances. And I know that someone had a question that we can address at the end about training, so we're happy to talk about that as well. But you're absolutely right. There is a lot of training that's involved. I think more of it affects the coordinators and the research nurses, but everybody is really super busy. And so we really need to have a mechanism in place to look at the training across all of the departments so people aren't negatively impacted. These are some of our metrics, so you can actually see the types of courses that we're doing. We do have the mandatory courses for the city classes. That was something that happened many years ago. The board of directors made a decision that they wanted to make sure that all investigators and all study coordinators had a baseline of training because we did have a few people that came through that didn't have training and there were some compliance issues. They work really closely with the Georgia CTSA, and some of the things that they offer through the Georgia CTSA is DSMB and DSMP. So they will help people develop their data safety monitoring plans. I think they have a list of people who are available to sit on a data safety monitoring board, but there is a group of people that work with that. We also have the rapid response team. So, we were here during the Ebola scare, and we were able to get the contract taken care of. All of the budgets, the IRB approvals were done within 24 hours. So we knew that we had people coming with Ebola that were coming over here from overseas. And by the time they landed, we had everything done. So that's the whole purpose of the rapid response team. We also developed an investigator dashboard that would help us to facilitate pre-award approvals. Excuse me, that is something that we've had a lot of problems. We had to switch platforms, and when we switched platforms, we had just issues with access. So this is going to be replaced by Insight. And as you know, I think the first phase of Insight is going to be coming out in the June timeframe. Some of the process improvements that we're working on is looking at to improve the experience of the training process. One of the things that we learned over the last 2 years is that there are a lot of people that are coming on board in clinical research coordinator positions that don't have prior experience. And so this has really been the first time in my tenure here that we've had so many people that are inexperienced with clinical research. So we had to go back and just reformat our training to make sure we could accommodate those people because they didn't even know things like what's the difference between a phase 1 and a phase 2 clinical trial. So some of the things that we're working on, we want to improve the experience of the investigators with the investigator consultations. And then we're doing some more work on the post-award side to help make sure that, excuse me, that the study team is aware of everything they need to know to do their job. So make sure they're reading the coverage analysis appropriately, that they understand the budget, that they know where to go look for things in the Encore system as well as in the Epic system. Next, I'm going over to the pre-award team. And this is where I just want to talk about some of the different divisions that we have from a pre-award perspective. So Dr. Lama talked about Dr. Harvey, and in February of 2024, he started the Woodruff Industry-sponsored Clinical Trials Group. This is a pre-award group, and the one thing that's unique about it, first, it only includes industry contracted studies. And the other thing is that in addition to doing the coverage analysis and the budget, they're also doing the industry contracts. So they have a whole group of people on this one team that is dedicated to the pre-award experience. And it's my understanding that she's going to have Dr. Harvey come and talk to you again in the future. In the middle is the Office for Clinical Research pre-award team. And this is Amanda's team. She's on the call. And we do all of the non-industry contracted coverage analysis and budgets. So we do federal, we'll do cooperative groups. We do not do federal budgets, but if there are any Emory Healthcare or Grady billable items and services, we would do the coverage analysis for federal. We do foundation studies. We have academic flow through. We do internal unfunded, and then all pediatric studies. So those are the ones where we're developing the coverage analysis. We will help to negotiate all of the budgets for the non-industry, non-federal. And then we also do the letters of intent if you need help there. We have a third group in OCR. It's the Clinical Trial Compliance Group. And these are the folks that make sure that all of the studies, either if they have billable items or services, that they're coming over to Amanda's group in the middle. Or if they meet the NIH definition of a clinical trial, we need to make sure that they're placed in the system so we can track all of the active clinical trials and active research participants. So they're checking the IRB regularly. We have some studies where they need to go in the system for subject tracking, for study coordination. We want to make sure that everybody is meeting the anything that is according to the FDA definition, the NIH definition, the ICMJE. We want to make sure are handled appropriately so you'll be able to publish when you want. So just to tell you, since we had the split between part of our group and the WIS group, that happened in February of 2024. We had a big turnaround, I mean, as far as a backlog of studies that needed to get done, which I'll show you in the next slide. But this goes to show you that we have worked diligently to improve our turnaround times. So we have, for total days, total calendar days, we have been less than 30 days since last February. And for business days, we've been less than 20 days since last February. And that includes from the time of submission to us until we're finished and we send it on. So that would be for the coverage analysis and the budget if it's appropriate. So you can see there's been some variation in the volume, but even with that variation, that we have made sure that we've maintained those metrics. This shows the backlog. So as you can see, we started out in that February timeframe with a very high backlog, and we just really worked diligently to move that backlog along. During that period of time, we were actually tracking the studies that were greater than 30 days and the studies that were greater than 100 days because we wanted to make sure if they needed special attention that we were doing everything we could to facilitate those studies. So this is going to show, we just recently went through a pilot where we were trying to figure out how can we make sure that we're providing quality coverage analysis and budgets, but we also want to make sure that at the same time we're improving our turnaround time. So we performed a pilot where we outsourced the coverage analysis and compared the time that for the outsourcing and to the time that we could do it internally. And I'll show you the results of that, but we did show that we were able to improve. I think it was by 6 days in time. We were able to improve it, which is a little bit over a week on business days, and that we were also able to save money by not outsourcing some of that. So that's one of the things we're taking to leadership now, so we can change some of our processes to make sure we accommodated the excess that we had with this pilot. The other thing that was pretty cool is that because we've been outsourcing some of the things to help us, like with Advera Boss is helping us to upload things into the Encore system. And we found that there was a lot of back and forth going on. So in the beginning, there was a calendar that had to be created. It was done sequentially, right? There was a calendar that was created. And then after that, there was a coverage analysis. Then there was a budget. But anytime we sent something to Advera Boss to upload in the system, any change that we made in those 3 steps, it had to go back to Advera Boss to make more changes. So not only were they charging us for it, but it was taking time. So we came up with the idea, and this was Amanda's idea. I give her total credit. She said, why don't we just wait to the end, do the coverage analysis offline, do the budget offline, do the development negotiation. We'll make sure that we get approval of the PI right after the CA, and we'll also get your approval right after the budget. Then we send everything to Advera Boss. Advera Boss will upload the coverage analysis, the budget, and develop the calendar all in the Encore system at one time. So we don't have any of that back and forth, and it really helps the system move much more smoothly and a lot quicker. Let's see. Another exciting thing is that research informatics was created, a new department, and they are going to do all the management and oversight of Encore. And if those of you are aware, the last 2 years it's been really tough because we've been trying to do our day-to-day jobs, but also trying to support the Encore system. So now we have a whole new department that is absolutely dedicated to everything Encore. Another thing, and I just wanted to solicit any feedback or if anybody's interested, but a couple of months ago, we created a new working group for non-industry budgets. So we want to take a look at, we noticed some trends of issues that were happening with effort that took a really long time sometimes to negotiate the budget. And lesser so, but there are other certain kinds of items and services that were included in the budget that may not make sense for those investigator-initiated studies, or if you get those studies that are non-negotiable, there's no way that you're going to get all this information through. And depending on the physician and how much money you make, if you did a minimum of 1% effort, that it might blow the entire budget out of the water. So we're taking a really close look at this. If there's anybody that would like to participate on that group, we would love to have you. Right now we have Dr. Schuster from radiology, who is an active participant, and it's just been really greatly helpful. We want to create a living document. So as we're going through and trying to tackle things in priority order, because we can't do everything at once, then we want to make sure that we're keeping a living document. We'll make recommendations, we'll escalate it through the research leadership, and then we'll try to go ahead and implement them along the way so we don't have to wait to update everything at the end. We also have Insight that's coming soon. So that first phase of that will be in June, is my understanding. And we also are looking at a new pilot to look at using AI to help improve the CA development. We want to make sure they're compliant, but it might help us be more consistent and do things in a little bit quicker manner. This shows you the pilot that we did to compare HHA, which is Hay Hill Advisors, whom we outsourced the coverage analysis to. And these, just as a comparison of when they did it for the all calendar days, weekdays, and then we did it all calendar days and weekdays. So it was 6.18 difference in the days, 4.51 weekdays, about a 20% difference, and a savings around 73,000. Just a little bit about the process. Essentially, what happens is that the OCR pre-award team and then also the WISC team for the industry contracted budgets will develop the final coverage analysis in the budget. That then goes to research informatics, who will send this information out to Advera Boss. They will do all of the things that we said. When that's completed, it comes back to research informatics. They do a QA of the process, and then they're going to send it for PI approval. And this PI approval is going to be a little bit different. So when we created the coverage analysis, we're going to contact you directly, making sure we have everything right. When we actually create the budget, we're going to do the same thing with you. This is after Advera Boss has put it into the actual system. We want to make sure that you're involved and that you are happy with the way that it looks in the system, and that your coordinators and research nurses are able to track their visits because the formatting and the content are correct. After that, it goes to our data integrity team. Vicky's on the call here today. They're going to release everything in the Encore system, and then they're going to push it over and activate it in the Epic system. Once that is completed, before she does that, she verifies to make sure that there's an E and a A. She makes sure that there's IRB approval. She also makes sure that the PI has signed off on it and that you have approved it. So this is just talking a little bit about the Encore optimization that went live on January the 21st. And just to help you know a little bit about some of the things that are new and different about Encore as opposed to 2 years ago when we went live in October. This is including a new PI sign-off after the Advera Boss build. to make sure that everything is okay from you and your study team's perspective. They're also requiring tracking of SAEs in the Encore system. And when these SAEs are tracked in the system, it will automatically go over and alert the OCR invoicing team for those industry supported studies so they can go ahead and send off those invoices to the company. There is the ability to track protocol and subject deviations if that's something that you want to do, but that is optional. And we've worked really closely on doing a lot of things that I won't even get into the detail. If you want to know more, please let me know. But we needed to make sure that we provided more information in the Encore system so it was available in the Epic system to the clinical trials billing department so they could review and adjudicate the charges. And so we've made a lot of improvements on the additional things that we do out of my office to make sure that Emory Healthcare has what they need so that there are no billing compliance problems. And down here, you can just see there's a service now. One of the things that Research Informatics is requesting is that if anybody has any questions or concerns or issues, to open a Service Now ticket. So this is talking a little bit about the non-industry budget working group that I mentioned. So I'm going to pass by this, but if anybody is interested in joining that group, please let me know. The clinicaltrials.gov and clinical trials compliance team is run by Jenny Prozonic. And this is one of the things where we have to help folks make sure that they understand the definitions of the NIH definition of a clinical trial, the ACT definition, which is part of the FDA, and then the ICMJE, the International Conference of Medical Journal Editors. Because if we don't adhere to all of the rules for these things, then people may not be able to publish, or there could be things that there's some very strict penalties that are involved now through the clinicaltrials.gov if things are not done in a timely manner. They're very specific timelines. So if that's something that you would ever like us to come and share all of those details, Jenny's happy to come forward and do that. We also want to make sure that things aren't slipping through the cracks as far as we need to make sure that anything that has Emory Healthcare or Grady billables comes for a coverage analysis and a budget. We need to make sure that anything that meets the NIH, ACT, ICMJE requirements are being handled. And so they're looking all of those things at the time of study activation. We have had really an overwhelming positive response from the investigators because they love the fact that we're doing most of the work. We're trying to compile all the data and everything you need to register study in clinicaltrials.gov. They've had to even take some people that have publications, they've had to deconstruct and reconstruct those publications. So they do all of the heavy lifting for you, but then it does come to the PI for review and approval. Some of our metrics, they've reviewed 451 studies over the course of time. We did find just this last year that there were 22 studies that weren't submitted for a coverage analysis, and then there were 49 studies that weren't submitted that needed to be activated in the Encore system. So we're just trying to help facilitate. A lot of times it's people that are new to Emory, maybe new to research. The other thing that we do in this department is that we have to make sure that even though we're only doing the registration and the results reporting for the studies in which Emory is the sponsor, we also have to make sure that for all studies, whether they're industry, federally funded, wherever, if it's going to have a something go out, charges go out to Medicare or any other federal payer, then it has to have an ECT number, an NCT number has to be listed on the invoice that actually goes out. If not, then it will be automatically rejected. I'm just going to keep on passing by. This information will all be available for you. If you have any questions, don't hesitate to let me know. We're working on the tracking of NCT numbers. We're hoping to make it a little bit more automated in the future. We're transitioning from a lot of our disparate systems, like people have heard of ERMS, OnBase. All of those things are going to be replaced with Encore and with Insight in the future. The data integrity team, we've talked a little bit about Vicky's group. So they are the liaisons between the university side and the healthcare side, and they're pushing, making sure that all of our studies are pushed appropriately over to the Epic system. There's a lot of requirements that go on over there. I don't think that you probably want to know all of this. The other thing is that just so you know, that there was a decision made at the very beginning with the Encore implementation that any subject that gets put in the Encore has to have an EPIC MRN, a medical record number. And so there are a lot of times that there are subjects that have not been in the Emory system, but because we want to make sure that we have all of that information connected and we're sharing that information, there is a REBCap request, and Vicky's team will help make sure that those patients get an MRN that they can open and put them into the actual Encore system. They do pushes of studies every single day. So there's no, if there are any issues, they're doing everything every 24 hours to make sure that there are no delays and there are no backups. They also are currently in the process, and we've done this for a long time, but our colleagues on the healthcare side wanted a copy of the informed consent document that was signed by the subject. And so we make sure that is put into the Encore system, but it won't go across the interface to Epic. And so we're having to upload that from Encore into Epic for our colleagues on the healthcare side. This is one of the things that Emory Healthcare Nursing has felt that it's a whole lot easier for the research nurses on the floor that are taking care of these subjects to take a look at the consent because they can see information in lay language. There's also something called a clinical research key points that is something that you all help to complete, your coordinators do, to let them know what they need to do on the unit. What are the research activities that you're expecting Emory Healthcare Nursing to do on the floor? This is just going to show you some of the metrics, but as you can see that just over the course of the last year, we've loaded 5,000 informed consent documents into the Epic system. A lot of transitions coming up. There's a lot of things that we're learning. We just went live a couple of weeks ago on the optimization. Next is the invoicing team. And so on the first page, this just shows you the different kinds of attributes of the studies that we actually manage. And just to say it at a very high level, it's any of the industry funded or industry sponsored clinical trials or clinical research. We'll do the invoicing for those. They don't have to have billable items and services, but a lot of the work that we do is because they have billable items and services. So I'm not sure that everybody realizes this, but if you have an industry-sponsored study where we're doing the invoicing, they're looking at these every month. They're doing a reconciliation. They're generating invoices for your study every month. They're actually making sure that they're processing all of the payments, and all of these things excuse me, are being done in the actual Encore system for all new studies. The old studies are still being managed out of ERMS, but we are putting the information of what we do in the ERMS system into Encore, and eventually ERMS will be completely phased out. One of the things I think people weren't aware of, because we would find studies would get close to coming to closeout, and we would have things that there was just a lot of confusion because there was a lot of turnover. Maybe the coordinators changed multiple times. And so every 6 months, we're requesting a full financial history from the sponsor. And so we're making sure that all along the way, in addition to our monthly reconciliations, that every 6 months we're getting the perspective of the sponsor so we can true those up and not wait 5, 6 years down the road to find out we have a discrepancy. So this just shows you how many active studies in fiscal year 24 and how many research subjects that had invoicing activity was 2,800. We reviewed 14,992 research visits because every visit could generate an invoice, right? During that period, during that month period of time. Our outstanding invoices were around 2 million. Our outstanding automatic payments were 61,000. which is just awesome. These have been in millions, multi-millions in the past. So they really are on top of these things every year. The payments that were received and reconciled for all of those active studies as of August 31st were 41 million. Payments received, not reconciled, 2 million. Study expenses paid, 1,000,005. So there are things that we are transitioning right now from the ERMS to the Encore system for all of our invoicing. There are limitations in the Encore system, so we're having to figure out how to do workarounds by some of those limitations. But our team's really been on top of that, and Veronique's really been heading that charge. All right, I think those are all my questions, all of my sessions. So do you want me to go into the questions that
Yeah,
were related?
Robin. Yeah, we could do that, Robin, or we could also open it up because, see, we first get the questions from the group here in case some of them have to leave later.
Okay, up to you. You let me know.
Yeah.
I have some comments and questions.
Absolutely.
Hi, Dr. Kayum.
And thank you for teaching me what OCR is, because it has always been a mystery. But it seems a massive undertaking. It's amazing that all this is going on. However, I have some comments and also some things that might help other investigators that are online. And my own experiences over the last 2 years where things I thought had gone terribly wrong with what OCR and all of these things that you listed have done at many different levels. And I'm wondering whether this is just a unique experience that our team is having, and we have a very large clinical trial business model, both industry as well as NIH funded. And we have been submerged in many, many issues, which I think I have described to many people in the leadership at various, but it's been very difficult to actually get down to actually having people solve these problems. And we have identified these largely because the billing system, if I could only ask about that, the invoicing and so on, it seems so wonderfully automated. Your patient comes in and Encore detects it, and you invoice and the money comes in, and within a month this has not been our experience. Study after study after study, there has been no billing done for months and months and months. Still, there are no billings done for some of the studies. Our managers, coordinators are directly calling the sponsors to see what is going on, and then they are sending the money in. We have no transparency in knowing who has been billed, who has been received. If there's money that came in that month, we don't know what it is for. So there is no idea. There are 7 visits on 3 people, and for this, and this, and there is a chunk of money lying there. There's nothing. You can't tell what it was for. Was it for the month before? So no transparency, nothing that we can look at. Is that going to change? And when is it going to change? And that's just with billing.
So, Arshad, can I have Robin first answer your question about invoicing? Because that seems like a very important question.
No, I know, but I want to get through all of these because there are 40
Okay.
people online, so I don't want to hog the whole thing. So I just list this as question number 1 or experience number 1. The 2, sponsors feel that our startup fees are excessive. Not many people, or not many institutions, even like academic medical centers, has these huge startup fees, sometimes like 23,000. And you can see why, because just OCR has like 15 departments that are feeding off of our startup fees. And maybe there is a sort of role for Elon Musk and Doge. The negotiating of the budgets, the coverage analysis. Especially after COVID, costs have gone up, salaries have gone up, and they've not gone up like they say 9% inflation rate. They've gone up, doubled a lot of these things. People's salaries have gone up. Every instrument has gone up. And the coverage analysis has hardly changed. Maybe it's gone up, I don't know. So what I've taken to do is to actually double or go up by at least 50% of whatever the coverage analysis and say this is what we need. And 90% of the time, the sponsors have accepted it. Sometimes they come down by a little percentage. So my question is, are you taking the new numbers that we have now got the sponsors to actually agree to, and then recalibrate how coverage analysis is being done, rather than taking that as a one-off, oh, well, you were lucky to get that. So I'm not, I'm actually using the coverage analysis to multiply it before offering it to the sponsors. So I'm telling this to all the other people online, because unless you're doing this, you'll never make ends meet, because things have become much more unaffordable in the last few years. And I had a few other things, but I'll stop there.
Okay. So thank you very much. We appreciate it. And you can contact me, any of you can contact me at any time, and we will delve into trying to resolve any issues that you have.
But we have tried, and we have had no response from billing people, absolutely zero.
Have you
Just
contacted me and I haven't responded?
I haven't contacted you. I don't know who they're contacting, because,
Yeah.
I don't do we have people who do this stuff, but we have tried, and it's
Sure.
not been just last week, for months,
No
to have some
problem.
of these issues sorted out.
I would just say that if anybody's having any problems, don't hesitate to contact me and I will get to the bottom of it. One of the things is that, and I'll let Veronique speak in a minute, she handles the invoicing team. But when we talked a little bit about the monthly reconciliation that we do, there's also monthly reports that are available in the system. So in the,
Tell you what they're billing for.
pardon me? Oh, the,
Doesn't tell you. No
so
idea what the money is received is for and what hasn't been billed.
I can
Doesn't say.
One of the things I can tell you is that we had a lot more information at our disposal in the ERM system than we have in the Encore system.
So
We
why
had,
did we go to a wrong system?
well, I think there were a lot of reasons why we went to Encore. It's probably its biggest asset was not invoicing, to be honest with you.
So why do we do it that way?
Well, we were told that we needed to move forward with it in every way that we possibly could
Robin,
Mhm.
for time's sake, let me put out two questions so that we
Okay.
can understand how to work on that. And thank you, Arshad, for what you brought up, because these are real issues. And thank you, Robin, for saying contact me directly. Thank you. We appreciate that. But let's first talk about invoicing. Do you think in Insight, our investigators will have more detailed invoicing information? And when do we expect that to happen? Because Arshad's point is a very good one. If we feel blinded to what we don't know, and Encore doesn't allow that, are we going to work with Insight to make sure our investigators are able to see that?
So we don't know exactly what's going to be in Insight or not, to be honest with you. So we have just started getting engaged in the January timeframe, but they haven't really started talking about invoicing. They've been focusing on the contracts component of it, and they've been focusing on the IRB component of it. It's my understanding that you will be able to see all of the financial information at your disposal in one place. My question is, and I think this is a good question that we need to ask, like Dr. Kayomi mentioned, will you be able to see an itemized list of everything? Because from what I hear from him, he wants to see an itemized list for each subject and the charges for each of those subjects so he can vet that, right? And so, and that's one of the things I'm going to, that Veronique can talk about, what's being tracked in the system, isn't being tracked in the system, and how that's converted over to the actual invoice. One of my concerns in the future with the Encore system, there are things that if they're not done appropriately by the coordinator, the invoicing team will never know it to make sure that it's put on the invoice and sent out to the sponsor. So there are things like the SAEs. If the SAEs aren't documented in the system, then they're not going to flow over to the actual invoice to get sent to the sponsor, and no one on the invoicing team will be aware of it. But I think that is really important, Dr. Lama, is to make sure that the physicians are engaged in the whole insight development process to make sure that they clearly understand the level of detail that you want to see in the system. And I don't know that they're going to be sharing all of that information from Encore, or if they're just going to be bucketing, aggregate information that they'll send over to the Insight system.
But
And
it is actually worse than that. And one of the things that we have dealt with, and this has cost us more than $150,000 that we are still trying to retrieve, is that, say, for example, this is a good example, and I think everybody else on the call should worry about this going back. And that is that we have, say, there's a visit 3, and there's got to be an echocardiogram that is being done in healthcare, so it's going to be charged from our grant, but it doesn't get done for a million reasons, right? It gets charged. The charge is already paid. And so you have a study where that had to be done, but it wasn't done. And Encore doesn't say it was done, but it gets billed. So we discovered that, most of our studies were in the red. This was about 6 months ago.
Vernique, can you comment on that?
Yeah. And really, we have put a stop to that. Like, you cannot take it into the healthcare without us ticking that it was done.
So I can't speak to the healthcare side, but I can speak to the Encore side. So the coordinator goes in and tracks exactly what was done at the visit. And
Course.
that information that's tracked at the visit is what is transferred over into the invoice.
Mm.
So if there is an error, that's actually made in the tracking component, then that's going to cause also an error in the invoice. I'd love for you to give me the IRB number. If you could send me an email offline, I'd be happy to look into the detail.
That's been dealing with this, and we've only retrieved half the sum so far. And that's what I call embezzlement fund.
No, but Arshad, obviously there's some problem in the system there that
Of course.
either they're checking echo and then Encore's marking it, or there is some miscommunication going on. So we can definitely try to figure that out. Robin, if we can send you that information,
Nice.
can I ask if anybody else has had issues like that who are on call here with invoicing, since we're talking about invoicing?
Yes, I don't know if the people I had been working with on a similar but smaller scale issue with venipuncture, if they are on this call, but they said that they were looking into it. Basically, it's a similar thing. If you put in an order and ahead of time, and you link it to the research study and the visit, and the patient comes in, and you don't end up needing a separate charge for it because they're getting standard of care labs drawn, for instance. So that should be rolled into the standard of care charge. Once the blood has been drawn, because it's been activated in the system by the phlebotomist, you can't link that one charge. We still get charged for the blood draw itself. And there's no way to undo it as a coordinator that I've found so far, and the other people I've spoken with. And that's a smaller scale version, but it's something I've seen in other ways too.
If
So
you can,
sorry, I was just going to say, I don't want to get too far off on all of the questions, but Isha, are you talking about Epic or are you talking about Encore?
I'm talking about both in a way. I assumed originally that if I checked something off in Encore as completed versus not, that might help inform the Epic billing.
It does not. It
I know,
does not.
I've learned, I know that
Yeah.
now.
Yeah. Okay.
But
Okay.
I'm talking about in Epic, there's no way to unlink something so you get charged once the visit's done. And you might
So,
not know ahead of time that
Mhm.
it won't be done.
I can tell you this, that we have a great clinical trials billing department, and just to kind of say that and then maybe move on to another question, that they are checking what comes through on the Epic side to see what is done or what has dropped bill wise. And they are also double checking with what is being documented on the Encore side to ensure that if you did mark NA for that venipuncture in Encore, that they should actually remove that from being maybe billed to insurance or directing it towards the grant. And it should not get billed to the grant if you checked NA and Encore. So just want to let you know that there are some checks and balances in regards to this, but I'm happy to discuss that logistically further if you like offline.
sure. And if you just send us your IRB number and we're happy to look into that, but just for everybody's benefit. So what you do in the Encore system, right? The tracking the visits in Encore is what feeds the invoices being created. Everything that happens as far as the charges dropping in the Epic system, all of those charges, what happens is that when we actually do a billing grid on the Encore system, it goes across the interface over to Epic. And
Mm.
then when the charges drop, it's going to go in specific buckets. So it could go into a research bucket and it gets charged to the grant account. It could go in a research bucket, but it goes out to third party payer according to the CA, or it could be in just a clinical care bucket. Those things are completely separate than what's happening in the Encore system. The way that once the charges are dropping, they drop in the appropriate buckets. They're being put on 100% bill hold for review and adjudicated by the clinical trials billing department. So those things are happening. So there could be so many issues along the way. We found out that there was something that when we had budgets that had effort in them, but if somebody wrote a note, even if it was effort, if they wrote a note on the Epic side, that it automatically generated a charge. So there's a lot of
Mm.
quirky things that are happening that we're just really understanding and learning as we go, as things are dropping into the system and we're trying to research them to figure them out. Initially, when we went live, there were a lot of issues. People weren't tracking the timelines, they weren't linking the encounters, they weren't using the research orders that caused a lot of issues as well. And those are being handled by a team that's over on the Epic side, but we meet with them regularly. So we're happy if we need to get everybody together, we're happy to do so.
So, Robin, it seems like this is a definitely, there are a few other questions I want to get to because there are other questions in the
Dr.
chat. Dr.
Savransky.
Savransky has a question, I think, right? Sorry, Charles, what were you saying?
No, I was just saying Dr. Savransky has a
Yes,
question.
yes, I was going to say, yeah, go ahead.
No, I was just validating that I've had issues, and I learned today, and thank you for letting me know that invoicing for subawardees, there was a CDC Foundation grant that we participated in, and we did not invoice for 29 patients, and only discovered this maybe 9 months after the primary awardee had closed out their accounts.
Mm.
And again, now I know that this is something that we'll have to stay on top of. And I guess having some place where this type of information is available so that our teams will know what you do and what you don't do would be extraordinarily helpful. And and again, I really appreciate you and your team's efforts to try to solve some of these issues. Thank you.
Thank you. We appreciate it. And we're always happy to help. And if we aren't the ones, like we don't do subawards, right? Even if we're not, we're happy to facilitating getting the right people together to help you.
Dr. Schneider, did you want to pipe in here?
Thank you. Yeah, I put my questions in the chat there. Curious to hear more about the pilot. I mean, I had a coverage analysis done in the midst of that pilot, and it was frustrating experience, honestly, to work with this external organization. So I'm just, I think maybe I'll see my question in the chat there. Just wondering what the endpoint was with the coverage analysis. Was it just the duration of time to return of the initial report, or did it include the back and forth that I experienced with the contractor just missing some pretty big things that delayed completion of the coverage analysis accurately?
Hi, Doctor. Hi, Doctor. I'm sorry, Robin. I'm happy to talk about the pilot. You're talking about the coverage analysis pilot where we did it with HHA versus
Yes.
and it was primarily really to see, like, could we save money and can we do it faster? And historically, we've always did the coverage analyses and the budgets internal. But then, there was growth, there was COVID, there's loss of FTEs and all of those things. So we really had to kind of outsource in order to get a lot of the work done. And during COVID, we didn't have a ramp down, we had a ramp up, and we were losing FTEs and, the money became scarce. So that's why we went to a lot of third parties to look at, like, how can we get this work done, because we're not slowing down. But HHA, I can speak very highly of them, and I understand your frustration with the back and forth. They are probably one of the best billing compliance teams out there. Internally, we did it. We are all trained before we actually outsourced to HHA in billing compliance and coverage analysis development. There's something to be said with our internal team having the relationships with the team and listening to our investigators about the coverage analysis and what should be there or not. One thing that Robin didn't mention is that we're actually going to be doing a pilot with Dr. Schuster about having actually one-on-one meetings at the time of the submission with the investigator and or study teams to be able to have a conversation with them to kind of say, hey, tell me how you're operationalizing this. Really, what are the billables? What CPT codes? Because we have some investigators that are very involved, like Dr. Schuster. So we understand that need to have more of that human interaction and that clarity up front for maybe the quick turnaround and the decrease in frustration and trying to get those things done. So it's not something that we have really implemented yet, is doing, and I can only speak for the OCR side. I cannot speak for the WIS side. We would like to bring them all in, but I think because we have so many changes kind of forthcoming specifically with insights, we haven't really had the green light to go forward with that yet. But it is something that we would like to do.
Thank you for that additional information. But are you able to answer my more specific question? Did the pilot look at just was the endpoint in time return of the initial coverage analysis report, or did it include the additional days that some teams may have or studies may have needed to ensure that coverage analysis was correct and moved to completion as a next step?
Yeah, so it really just analyzed from the time it's submitted to the time, sorry, excuse me about the dog, to the time that it actually came back and it was finalized. So it included the PI return, feedback, everything. Included the development. It may even have included the budget if there was a budget, and it also actually included all of the encore entry. So it was from the time it was submitted to our department to the time it went out of our department, and included all of those processes. I did not look at the specifics though, like how long did it sit with the PI and their team, or how long did it sit with us to do the development. I did not look at that. It really just kind of looked at the full scope of it. How quickly did we do this? And I think it's always been known that when you do the coverage analysis and the budget together, it is really expedited, to get in and out faster, where versus, you do the coverage analysis and then you do the budget, it kind of slows it down a little bit.
Thank you.
Yeah, sorry.
I'm so sorry. It's 1 o'clock, so I can let, obviously if people want to stay on and they're happy to, I'm more than happy about that. But I did want to finish our session, but I think I want to sum and say that this has been actually quite eye-opening for me, because I have some of my most prolific clinical investigators here. I'm listening to their problems, and I'm also hearing Robin, that they did not know about some of these operations, right? So, we always talk about darkness under the lamp, and I think it's the same thing. We need to improve upon that. Bridget, I love your suggestion of us doing something to for two areas, the invoicing, which you said, and I think that's what you're suggesting there. And you guys are better at this, but what I am understanding is two main issues. And I think we thought about those, Robin, before too, when me and you met or we met together. Invoicing comes up, like Dr. Kayumi said, and the second comes up is the coverage analysis. If we don't start with the right coverage analysis, our investigators are going into negative deficit. And that's a big issue. We talked about this before, that your team does a great job, but they're doing it in isolation without getting much feedback. You might put something for a bronch, but my bronch cost might be different because there is anesthesia with bronch, which your team might not know. So I think our involvement in coverage analysis is very important, and that's another area we need to look at. So I'm identifying two areas from our discussion here. One is invoicing, and second is coverage analysis, where we think we need more information and more flow of it across the room here. So we can think about ideas on how to do that. If you guys want to suggest something to us, please write us an email. You can send it to either Kanika. Kanika is our new project manager, or me, or Dr. Searles. And we would love to hear how we can facilitate this more. We can do town halls, like Bridget said. We could do some special sessions. We could have the team come again. I think, Robin, your team's expertise is very much appreciated, and also your interest in streamlining this process. We thank you for that. So that's, so please, if you have any suggestions on that. Otherwise, we will focus on these two areas of invoicing and coverage analysis. So any other suggestions in the last few minutes, and then we will close the session. Does everybody agree two areas we should focus on: invoicing and coverage analysis?
Agreed.
Okay, thank you, Jason. Thank
And
you.
if we have any volunteers that would like to run with the pilot like we're doing with Dr. Schuster, we would love to have a couple of volunteers, and that would give direct support and feedback to your team as well as to our team. So we're happy to help.
And then, I think there were some examples which came up, Robin. Those might be good for our investigators to bring it to your office for you guys to look into why things were happening the way they were happening. It might help us streamline some processes, like the echo and the blood draw example.
Absolutely. If you could just send me, an email, send it to me. I'll make sure that we get together and work on it. But I need the IRB numbers so we can find the specific study so we can start the research on it.
Great. Thank you, everyone. And please pass the word on that this is recorded. So if anybody else wants to listen to it, they can. And, hopefully we will have more of these sessions in the future. Thank you again, Robin. And thank you, Amanda and Bridget and Vernique and everybody from your team. Thank you.
All right.
Thank
Thanks,
you.
everyone. Appreciate it.
Bye.
Bye.
Bye.